distinguished discussants. The first is my colleague, Alpha Senkepi. Alpha is a pandemic health journalism mentor with Internews in Liberia. The second is Gideon Kawami. Gideon is a broadcast trainer and a rural and community development journalism practitioner from Ghana. He's also a member of our Internews Health Journalism Network. And the third discussant is Babatunde Okunlola. Babatunde is a development journalist and head of programs and content at Diamond FM, Osun State in Nigeria. Now, before I hand you over to Professor Morineke, here are a couple of housekeeping rules. Number one, please mute your mics at all times if you're not talking. Number two is that post your questions to the Q&A channel. And thirdly, this is quite important, there is a simultaneous French interpretation. So please choose the interpretation channel by clicking on the globe at the bottom right. You see the globe, bottom right. If you do have difficulties, please send a chat message to the host, yeah? And we will help you with the translation. Now I hand over the webinar to Professor Morineke. Morineke, on to you. Thank you.
Thank you so much, Sonny. It's indeed a pleasure to be here. And yes, I'm looking forward to the erudite discussions as well as the questions that every participant will be sharing. For the next 1 hour, I will be working with Fala to highlight issues that we think it's going to be critically important to understand to help us, find ways of addressing barriers to vaccine access or vaccine equality within the West African region. You did hear the beautiful background that Sonny just shared with us in terms of what it is. I mean, the world is doing something extraordinary in terms of distributing COVID vaccine, yet there is inequity in terms of access. So over the next 1 hour, we'll be looking at two broad issues when we're talking about vaccine equity. We'll be looking at the supply side. What does it mean for the countries in West Africa, the grassroots, and the very persons that need it to have access to this vaccine? And the second will be about demand. It's possible to get it to the grassroots and nobody believes in it, and therefore uptake and utilization becomes nil. And no other person could as well be better chosen to discuss this with us. Welcome, Dr. Fala. I'll start by asking you a few questions, and then I'll leave it up for you to discuss these few questions. I think for us to understand, thank you so much, sir. Apologies, I should have allowed you to say that. So for us to understand what might seemingly be a challenge in terms of COVID-19 vaccine access, we know that in Africa, we have the West and Central African region, Eastern African region, as well as the Southern African region and Northern African region. Of all those regions, the West Africa is doing, West and Central is doing really poorly. So can you please help us understand the West African context that otherwise might be having an impact independent of any other thing on the COVID vaccine rollout agenda? Why do we have this low rate? And why are we seeing low hospitalization? Why are we seeing low deaths? What could otherwise be the reason? I look forward to you to answer those few questions. Over to you, sir.
Thank you very much for the opportunity, and let me know if you hear me well or there are sound in the background. A few months ago, we tried to write an article along with the Director General of the West Africa Health Organization. Addressing this very particular issue, why is it Africa was performing so poorly, even though she accounts for about 1/3% of the population. 1 in 6 person is from Nigeria. 1 in 6 African is a Nigerian, and so that places us in terms of population at the highest level. But overall, at the time we wrote the article, West Africa had around 4% vaccine coverage, with some country performing less than 1%. Having had the opportunity to work across multiple countries, multiple regions, couple of factors I think that has not worked in our favor. One, strong leadership in some of the countries that we're working. Pre-existing partnership has helped countries like Rwanda to give a large consignment of vaccines through the bilateral donations. When we were in Rwanda, the issue was finding additional coaching to accumulate vaccines. Some time ago, we wanted to give some vaccines to Tanzania, and they said to us, "Oh no, we don't need vaccines right now. We are not worried about vaccines." So there is a global skewness of vaccines towards maybe Eastern and other parts of Africa compared to West Africa. Also, don't forget that some of these countries, because of their stronger economy, has been able to procure vaccines, or through the Harvard project, has been able to acquire vaccine through bilateral means. So we saw that happening, that yes, indeed, West Africa was lagging behind. There are not many countries in West Africa were procuring vaccines through the Harvard. Donations to the countries in West Africa was a bit low. And let's face the philosophy, some countries have strong leadership and they work a little bit harder. Some of the strategic bilateral relationships were critical. Let me make a disclaimer here. I'm already speaking as a scientist and not on behalf of the Africa CDC, so I rather make that disclaimer. But we do know that when we come to look at the issue of supply side, there were two things that were affecting us. One, the vaccine inequity was amplified by strategic vaccine nationalism and diplomacy. Individual countries were negotiating and giving vaccine supply as a way to strengthening their diplomatic relationship. We saw that happen in some countries. Some countries that they felt were strategic had vaccines, and fundamentally there was the issue of economy. Some countries have back up were acquired vaccines by themselves. So in the case of, like, say, Zambia, in addition to other stars they got, vaccine was entered the Harvard platform to procure vaccines. So basically, leadership, strong leadership, strategic diplomatic relationships, strong economy, they now work strongly in our favor in West Africa in the early months. I don't know if I've addressed it, I can go more deeper, but basically these are some of the factors we've seen that these three factors did not work in our favor strongly. I mean, there was selected country across West Africa that got vaccines because, again, their leadership structure, strategic relationship, the strength of the economy to farmers to procure the vaccines. The global push, either through COVAX, the global push also tried to get countries based on their strategicness, population size, the prevalence of the disease also pushed towards the vaccines. I will probably stop and maybe take follow-up question.
Thank you very much. I mean, those are really insightful, and for me, actually, new information in terms of looking at factors that not only affected demand, but also supply. I'm going to push a little further, exploring this issue of supply. And I want to share with you some of the things we otherwise are thinking, and maybe you want to dispel these myths, if they are myths or misconception. For example, we felt that there was global vaccine shortage because of India diverting vaccine supplies meant for Africa through COVAX to meet domestic COVID-19 crisis. And we felt that this diversion might, in one way, actually have affected, of course, the global supply, but was affecting West Africa, who doesn't have the strength in terms of leadership, in many places, strength in terms of economy, or strength in terms of strategic political partnership. Do you think this might have played out in the disfavor of West Africa? And that's one. Secondly, also, what do you think about the issue around vaccine dumping, where we're seeing very close to expiry date vaccines starting to arrive in countries, especially West Africa. And therefore, its use was not possible. The use counted against us as countries, but then also counting against us as people who cannot, or people can't take vaccine because there's vaccine hesitancy in the country. What role did you think the donors played in this context? Over to you. Thank you.
You raise very key points. Let me start with some very stark number and statistics. Even before COVID-19, Africa imports 99% of all of the vaccines. Africa does not have infrastructure for manufacturing of its vaccines, has not committed itself to committing resources for vaccine manufacturing. So even before COVID-19, 99% of all the vaccines we use for routine immunization are imported. So obviously we are very vulnerable. If we take a step further, we wanted to do diagnostics. We couldn't get diagnostics because we don't have the means or the infrastructure to manufacture diagnostics. So we started this whole COVID very disadvantaged. For whatever reason, we thought that it's not worth us investing in vaccines. A continent of 1.3 billion people. That was one. Two, I started doing this advocacy before I joined CDC on the issue of vaccine access and equity. I wrote several articles. So we wanted to take a letter that, together with 118 global health experts, bioethicists, wrote at the World Health Assembly, and we're trying to take the letter to WHO, the last World Health Assembly. But the requirement was that we needed a sponsor. We needed a country to sponsor us. And so I reached to one of my friends in one of the European countries, which I don't want to disclose the name, and asked if they could sponsor through the foreign ministry. Very good friend of mine. She agreed, except she told her the country was reluctant to sponsor us, to put us on the agenda, because we had the issue of one of the conditions, the waiver of the patent, so that they can technology transfer and waiver of patent, that the country was reluctant to sponsor the agenda because we had that, the letter, because we said that the developed countries should allow Africa to have access to the patent and then access to the technology transfer. Taking a deeper look at that, there are several reasons we can look at. One, I think that we've produced more billionaires in the COVID than ever before. So let's agree that we have economic implications. People want to maximize this. Number two, we started the argument from a moral perspective. The first argument was saying that we're speaking the issue of equity, solidarity, asking that we need to protect everyone in the world. But we realized we're not making, no one was supporting us. We're not gaining any traction. And one of our colleagues said to us, and this person is an American, and said, Musoka, we have to shift this argument. The moral argument is not gaining traction. We have to shift this argument to a collective security argument, that if you do not support Africa, Africa could be the next place for the next variant that will affect the world. And true to it, we saw that happening. Most of the vaccines you see today that is camping, what you call the vaccine dumping, started after the Omicron, when it was discussed among immunocompromised people in Botswana and Southern Africa. All of a sudden, then the argument is more from a security perspective. On one hand, if you look at it morally, you say maybe the Western nation and the developed nation are wrong not to share the vaccine equally to everybody. But let's ask ourselves a question also. Why are we as Africans not committing to investing in manufacturing? One of the leaders said to me, one of the higher level advisors to the president said to me, Musoka, we are elected by our people who can provide for their security and safety. Until we can take care of their security and safety, we are not going to take care of Africa. That's one. So it was both economic, nationalism was playing the part. People were hard. In fact, there was a time where Canada had enough vaccine to vaccinate one citizen 10 times. People were procuring vaccine even before the raw material was being procured by this developed country under extreme nationalism, which we thought was not good. Then we come to the issue of the vaccine dumping. We agreed after the fear of Omicron, people started to give vaccines to Africa. I've been to places, I won't call those countries, and they have vaccines. One of my jobs is to help country to avert vaccine expiration by moving money and resources. It is very sad. Letters has been written and said, give us a vaccine that has 6 months shelf life. But you know, we have a serious situation. One, the donor country wants to give away their vaccine that are about to expire. And because we haven't invested with disadvantaged Africa, we accept those vaccines. Some of them having 2 weeks, 3 weeks shelf life. We just think it is wrong. There was a point in time we're asking and we couldn't get it. And now we're giving the vaccines, and our reviews on data, I won't tell you the country, but they have almost 2.8 million vaccines that are about to expire in the next 2 weeks. The end result, it has consequences. These vaccines come to us with short shelf life. They will expire, and we appear like Africa are not responsible, Africans are not responsible enough to take the vaccines. That will come later when we discuss demand. I will speak to the issue of demand. And one of my colleagues from the World Bank said the issue of demand we are asking, is it the lack of demand because there's no steady supply to Africa? Or is it a lack of demand because the Africans are not interested? Those are questions we have to ask. Thank you. I will start for now.
Thank you very much. I think those are really excellent issues. Before we leave the area of supply, I just want to probe a little about the issue you raised, where we're going to push on the conscience of the big brothers by raising the issue around collective security. But you also raised earlier that one of the issues we're seeing is the low investment of African government in vaccine itself. Of course, you could, I mean, if you want to defend that, I'm not sure I will defend that, but there are statistics that helps push and help to see that itself, African government cannot raise the needed capital to do all it needs to do, including manufacturing. So if we push this argument to the plane of collective security, I'm sorry, I know that I'm supposed to start my video, but I explained earlier that my bandwidth, I'm conserving my bandwidth right now. I'm sorry, I'm not putting on my video, thank you. So if we now push the argument to collective security, how do you think that would affect, or has so far affected, the supply, knowing that we as a country, we would put our hands down in terms of our ability to address security? We're not doing well in terms of security as a whole. How much more this, ethical security tag? And as you would see with this conference, we're still pushing the equity angle. And maybe we just may not be succeeding with the equity angle. I'd like to hear your perspective. If you are going to work as a journalist, which angle would you push? The equity and solidarity or the collective security angle, and why? Thank you. Over.
You see, the line between collective security and this issue of equity and morality, I realize it comes down to two things, geography and economics. I will come and tell you why. Because there were countries that had infrastructure, like South Africa. India, there were countries that were asking for patent and technology transfer, but they were not released to them. It took a long advocacy, and to work on that. There were countries that had infrastructure in South Africa, for example, Egypt, that were making the appeal, but they haven't gotten it. Until very recently, nobody supported the issue of, I told you that my colleague from this advanced country, they couldn't sponsor the letter we asked them before the World Assembly because we asked them on the issue of patent waiver and technology transfer because it has economic honor too. So again, it's becoming like a duplicity, but it's not strange. You and I know the reason behind HIV is the only reason why you had HIV available to Africa was because India and Brazil were able to get the ability to make generic market. And then people came back with the issue of the moral. So again, it's difficult to understand whether it's really morality or it's really strategic advantage or it's really economics. All of those people who made the vaccines, the prices they made, they are all billionaires today. Some of the argument we're putting was, can you lose some of the billion to make the world a better place? Then we'll come to Africa. I mean, we haven't done well, but I have to say that COVID has given us a wake-up call. At least I do know that a few weeks ago, Ghana, Senegal, and Rwanda met in Marburg, Germany, with our boss, Dr. John, with the WHO Director General Tedros, to begin pioneering work on vaccines, on COVID vaccine manufacturing. So some of those things are taking place. And our colleagues from Mastercard were telling us they visited the manufacturing site in Senegal. They were very impressed. I'm in Ghana right now, and I've seen the progress Ghana has made, that they have a goal, ambitious goal by 2024 to be able to manufacture their vaccines. But what is encouraging for me in Ghana is the fact they are using that platform to address the issue of malaria and TB vaccines. So yes, it's been, so we have 3 countries. Of course, we do know in South Africa, the mRNA vaccine hub has begun. Egypt is making progress. Morocco is also acting. Africa CDC through the SLF program is trying to see how they can build based on those existing platforms to train the technology, train people, send them to India or other countries to get training. Because I think there's a big ambition now that we cannot continue this way. We have to shift to the point where we start to produce our own vaccine and diagnostics. Yeah.
Excellent, excellent. I think for me, if there's anything that the COVID-19 had made happen, is this push for local manufacture of vaccine. This has been on for a long time. Even AU actually had a document about local manufacture, but that is one big point. But then let's shift to the demand side. What's going to drive?
Professor Morenike, just one more question to Dr. Fala, and then we'll go to the discussions. And there are a lot of questions coming in now from the audience. Yeah. So
all right. Thank you.
One more question for Dr. Fala.
Excellent. So we'll just. Thank you, Sonny. Excellent. Thanks for helping me to check on people. So I'll just ask this one more, and then I'll turn it over to you, Sonny, and help with the Q&A. And we'll ask this one question about demand. I'll put it on your table. If the supply comes and the manufacturers come and we have, and everybody decides to give the money and make it available, how well will we mop up in terms of demand? Do you think the low demand has all to do with inavailability of supplies? Or is it truly that there's a large population on the continent that truly do not believe in the vaccine for whatever reason, including the fact that there's low death, low hospitalization? Over to you, Dr. Fala. Thank you. And thereafter, I'll hand it over to Sonny to help me with the Q&A. Over.
First question, and this is a question that I myself keep me awake every day, and I will try to unpack it slowly. Step one, we are no more having the issue of lack of vaccines. Since Omicron, most countries have a lot of vaccines, either through the COVAX, through African Union and Africa CDC, AVAT, through bilateral. Almost every country has some vaccines. Supplies for the time being is not an issue anymore. The issue now is demand generation. I will look at this at several levels. Let's start with first infodemics. Today, with the advent of the social media, the typical person has gotten bombarded with many conflicting information that they begin to question if this thing really exists. So there's no misinformation, disinformation. The second is that, let's face the reality. I've been in Ebola work, I've done in Liberia with TRC. When the African wanted the vaccine at the time, they couldn't get the vaccines. And they have believed more. They don't see the risk of dying now before them. So you see that has also played a key role. But also what we found out is that what we call, how do we generate demand in an innovative way? Because we have some evidence to show that if we're innovative in demand generation, we can see vaccine uptake. I will walk you through that. One thing we've also found out, sometimes the thing we call lack of demand is a lack of access. Lack of access may be translated as lack of demand. People are not interested. One, how do we expect a mother to leave her job or market or the farm and work 1 hour or 2 hours to get vaccines for a disease she does not perceive is killing her and her children? That's the first thing. We are not making vaccines as easily accessible to the people to get it in a more comfortable and convenient manner. Right? So that's become, what is the incentive? That's the first thing we have a problem with, providing access in an easy way. The second issue we found out is that The last mile distribution is a problem. We have to move the vaccines in the interstate to the people where they are, which starts with the first one. The lack of use of influential people, community people who are influential, is a strategy issue. What we have seen in multiple countries, I was in Tanzania, I've been in Zambia, I was in Ethiopia, obviously. What we consistently have seen, countries that have done extensive job with mass campaign, we have seen vaccine increase to millions of doses. We've seen that wherever there has been, I think Ethiopia came from 2% to over 10% of this population. Talking about 116 people. They did that within 1 week of mass campaign. We see that happen in Kenya and Uganda. One thing we are pushing to do the mass campaign. The only challenge with the mass campaign, it is resource intense. It is both human and financial resource intense. So we've seen a country that has, and then the second thing we did was in countries that we invested where the people take the vaccine to the people and now sit within static site, we are seeing increase of that demand. How do we work on that? And the overall concept, both from politicians and ordinary people, that Africa have missed the bullet. For me, that's the biggest fear I have. We have seen many variant forms. We came from the Delta variant, where many of our people die in Africa. We have the Omicron that is less virulent. The fear that I have is this: what if we have a more virulent strain tomorrow? One, we only have 17% coverage. Two, studies have shown that people that enter the ICU in Africa, 60% of them will die. So what if tomorrow we gave the impression that we don't want to use the vaccines, and a more deadly variant comes, and we have not covered ourselves? So basically, the word is for us to work harder. The vaccines, so we create awareness to be able to build this demand, but we cannot afford not to increase demand. Thank you.
Thank you so much, Dr. Fowler. Brilliant discussion. And I think that also would set our journalists thinking. I mean, the government is doing supplies, we have to do demand. And so I'm going to turn to our discussants here today to ask of you, what are the challenges you face in the field while reporting on challenges to equitable access to vaccines? When you talk around vaccine shortage, barrier to vaccine uptakes, and what issues do you think you can bring to the attention of the policymakers and the public? And finally, do you think we have a community of journalists that can help facilitate economic development in the region by pushing for investments in COVID-19 vaccine initiative as an indirect mechanism of strengthening the health system? I want to first start this discussion session with Alpha Sekempi. I apologize if I pronounced it wrongly. Alpha is a pandemic health journalist mentor with the Internews in Monrovia. Over to you, Alpha. Thanks for being here.
Thank you very much. It's Sekempi. It's Alpha Sekempi.
Thank you.
Okay. Okay, I know it's a difficult African name. No, so Dr. Fowler presented a broader picture from a more scientific or policy perspective, but from the situation on the ground here in Liberia, I think you can draw in from some of the things Dr. Fowler said, for example, demand generation. And I actually wrote that down because I think that is one of the problems in Liberia. Whether or not we have vaccines in the country, I think we do have vaccines. Whether or not vaccine intake is pretty much impressive to meet the targeted goal, I would say no, because just collecting the data
today from the experts who work at the Ministry of Health and NFIL, it shows that Liberia has vaccinated something around 1.4 million people, a little over 1.4 million people. If you look at that target, that's not where we want to be, because a population of around 5 million people, and you've just vaccinated less than 1.5 million people, it shows that the vaccine intake is pretty low. Do we have vaccines? Like Dr. Fowler said, yes. I will not measure whether or not the quantity of vaccine in a country can serve the entire population based on the numbers I've gotten so far. But But if you also look at how the current situation of the virus is in the country, I think it has maybe some impact on how people are considering getting inoculated with these vaccines. So say, for example, right now, the latest report from the National Public Health Institute, April 25, shows that we have just 6 confirmed cases in the country. On an overall, we've had something around 7,400 cases, or something around 294 deaths, total deaths since the pandemic started, and over 7,100 people have recovered from the vaccine. I mean, from the pandemic or the virus. Drawing that and measuring it with how the vaccine had how the virus or the outbreak has devastated other countries, you would say we're pretty much lucky because we've had maybe the severity of the vaccine, the impact here is little lesser than what has happened in other African countries like South Africa, like Morocco, and even Nigeria or Ghana or even Kenya. But I think getting people to change their behavior towards whether or not if the virus is raging hell or not, it's still important to take the vaccine. It's the key thing to do because a lot of people tend to be lackadaisical if they think that the virus is not really raging hell like it was doing a couple of months ago. They think they are still free from the virus, even though they are not gotten vaccinated. And there's also this argument of herd immunity, whether or not herd immunity is protecting others who have not taken the vaccine so far. So these are questions that continue to linger. But the bottom line is, and I agree with Dr. Fala, and that's what I like to emphasize as well, considering my own experience and observation of the situation here in Liberia, that we need to do more rigorous communication, social behavior change communication to ensure that, yes, even though we do not have too many live cases of the vaccine, of the virus or of the disease, but it is important to get the vaccines. And I think if we have more people getting interested in taking the vaccine, if we can just pass maybe 50% of the population taking the vaccine, that would tend to show probably to motivate, like the COVAX facility that they continue to give us a lot of vaccine, AstraZeneca vaccine. We've had over 192 doses of the vaccine. We have over 834,000 of the Pfizer vaccine in the country. A lot of people have been taking these vaccines. So I think the more demand for the vaccine will come when more people show interest, and that will come, that interest will be generated if the more publicity, there's more discussions around the importance of taking vaccine. And then even though we do not have a severe cases of outbreak in the country, but people will have interest in taking the vaccine because of the long-term benefits that it presents.
Thank you, Alpha. Thank you very much. Great perspective. I'm going to shift now to Gideon. Gideon is a broadcaster, trainer with rural and community development journalism practice from Ghana, and he's a member of Internews Health Journalism Network. Please do put on your video. For Gideon, I'd like to build on what Alpha left unfinished. So if you also do believe that community engagement, community drive is important, I would like you to share with us your thoughts on the kind of messaging that you probably would think would empower, or the kind of messages that you think your colleagues as journalists need to push in there to drive the demand, even if vaccine becomes available. Thank you, Gideon. You have 2 minutes to do this. Over.
All right, thank you. I want to, for the sake of my bandwidth as well, I want to take off my video, and I hope it's okay. Now, to answer your question, yes, in Ghana, as we speak now, the number of people who are vaccinated now, that is to say, those who are who have been put in the dosage, are about over 9 million people, which represent about 28% of the entire population of 13 million. People who are completely vaccinated are just above 5 million, making about 16 point something % of the population. Recently, the president of this country kind of like lifted most of the mandatory, protocols, the wearing of face mask and all that. Ghana is doing well in terms of campaigning for people to get vaccinated. But one of the things that I would want us journalists to take critical look at is how government is able to hype up the people's interest in getting the vaccines. Now, yesterday, the health ministry and the health service reported a zero admission of any COVID-19 patient. And so these messages are making people think that, well, after all, the virus is no more serious in the country. And so people become reluctant in getting to get the vaccine. But I am trying to see that journalists need to dig deeper into this and bring up the messages to let people know that, yes, probably we do not have current patients on admission with COVID, or you can say that the transmission is low in the country now, but yes, still, it is not over. It is not over. We have not been able to do away with the battle, the COVID at the world level. This is a pandemic. And so before we declare that we are all free, the fact that one country might be free from it for now does not mean that we are all free from it across the world. And so this is where I want us as journalists to concentrate probably our reportage on the fact to whip up people's interest that, yes, we might be comfortable at this point in time, but across the world, the virus is still on, and so means that we cannot relax. Because in the beginning, it was not from Africa. And so there's the need for us to say that, yes, once we are free for now, it doesn't mean that we are free forever. And so we need to kind of like still whip up the interest. Now, one other thing that we've also, we've taken notice of is that the vaccine is not being made available at permanent places in the communities. Government is now doing what we call national immunization days for COVID-19. And so once in a while, the health authorities will drive a campaign for 2 weeks, go around house to house and vaccinate people. But what we are fighting for is that once we have the chip zones and the health system, could we have them, the vaccination centers, as permanent? This will now make it more accessible to the large population to get vaccinated. Thank you.
Thank you so much, Gideon. It's brilliant listening to what's happening in Ghana, and I must congratulate your country for doing well. I'm going to move over to Babatunde Okunlola, who's a development journalist and head of programs, actually content expert with Diamond FM in Osun State, Nigeria, very close to me. And I'd like to hear your perspective from what you've heard today. We've heard about pushing vaccine equity. We've heard about pushing solidarity, and of course, issues around collective security. What will be your game-changing strategy as a journalist when you're thinking of Nigeria, knowing that it's the giant of Africa? If we get it right, West Africa will probably be covered. Over to you, Babatunde. And sorry for putting you on the spot.
Well, thank you so much. It has been an honor listening to this conversation, the amazing questions, as well as the answers by Dr. Fala. I think it's also interesting. My colleagues have had a lot to say. And one of the things of the COVID pandemic and, the vaccine attempt to get people vaccinated has made us realize is that a lot of health issues generally are interconnected, they're intersectional. And one of the challenges in terms of getting people to accept to get vaccinated, like Dr. Fale and my colleagues rightfully pointed out, hasn't been so much about the supply right now, as much as people stepping forward to do that. And that's because, for example, people wonder, it's the trust deficit in so many cases. That still remains a thing. There are a lot of other issues that people have had to deal with. So you're not concerned about some other basic things that affect me as well, but you, for some reason, I'm supposed to trust you. And so governments still have their work cut out for them in terms of these other areas. The economy hasn't also helped out in so many cases, because then, like Dr. Fale pointed out, using the Tanzanian scenario, that no, this is not what we need, this is what we need. So in order to also get people to be concerned about that, there is a need to also meet their needs, perhaps meet them at the point of needs at some point. And this is not just a government error or inadequacy. Journalists as well have been guilty about that, because we move on to some other things. The way you push out the stories, it's determined by your editor, your organization's interest in some cases, and these are major determinants. The vaccine story is being pushed out more than we've ever had it before. But then again, it's about how consistently, how we're able to pass across the messaging in so many cases. So if there's going to be any game changer, it's that in pushing for equity and, a couple of other things, it's been able to gain the public's trust in these cases. Speak more about it, but then again, also pay attention to other issues that affect them as well. I think this is going to be a game changer in so many aspects on the continent. I also put something down here when Dr. Fale was discussing the issue of fake news and disinformation, misinformation, certain factors like, vaccines nearing the expiration date, being passed across to the continent. These are some of the things that have also dealt heavy blows. But then again, as journalists, we have to report all of it and not and trust the public to be able to make informed decisions as well when it comes to choices like side effects, some effects, of these vaccines as not being deadly things. These are some of the important things I feel as well.
Thank you so much, Babatunde. I think we've come really, really, kind of honing in very well with the background that Dr. Fale shared with us and how you discussant has brought it. If there is anything I'm going to summarize at this point, is that what I've heard in these final words is that we've kind of positioned vaccine as synchronous with as the government. We see the problems, we see distribution, we talk about demand, and that has kind of circled around the government. But we just might start doing a lot more and pushing uptake once we start positioning vaccine stories as a personal story. It's about you making a difference, be it equity, be it solidarity, be it security. If we start, and just as Dr. Fale said, the change they're seeing is when they started working with the community. Once you start seeing vaccine access as you, and not just as a country, as you, a unit, that makes a whole difference, then we just might see the drive and the change and prevent the problem Dr. Fale is truly concerned about. On that note, I would like to say thank you to all discussants, excellent contribution, and hand over to Sonny, who will be taking the QA section and bringing us to a close. Once again, please drop your questions in the Q&A box or the chat, and we'll take it over from there. Over to you, Sonny. Thank you.
Thank you very much, Dr. Morenike. These are the first two questions. I'm combining the question from Arthur Fidelis from Cameroon, and also I'm combining a question from Judith Blue. She's from Cote d'Ivoire. The question is, isn't vaccine inequity and injustice of vaccine producing countries on African countries? And then from Judith, I would like to know your response strategy against COVID-19, how to manage this percentage of, I think there's a correction here, of 70% as desired by Africa CDCs. On to you, Dr. Fale. Thank you.
Okay, thank you very much. I would want to start with a key point that Babatunde spoke about, the trust deficit. What we have seen, or again, on the trust deficit is that, 1 second, please. Oh, sorry. Yes, sir. The issue of trust is everything. I will give you an illustration. 2 countries have achieved phenomenal effect when it comes to vaccines. Rwanda, and Morocco. We've taken countries to Rwanda and Morocco. And the thing we saw that, so example, in Kigali, they have achieved nearly 100% vaccine coverage in Kigali. They are around 65% vaccine coverage in Rwanda. The same with Morocco. The fundamental thing we found among these two countries is that they have pre-existing trust with the government entity. There was universal health coverage existing. In the case of Rwanda, to immunize people 65 and above, every person who is 65 and above in Rwanda is copied in the database for support service system. So pre-existing trust is everything. People trusting their government, one. Two, the trust also goes down to the communities. We saw that trust is everything. Now the issue of 70%. 70% is not only Africa CDC's debut issue. I want to address it from two perspectives. One, it is the number of people that need to be vaccinated so that we can have herd immunity, which means such that the vaccine can be protected. If you imagine a group of cattle going and they put the weaker ones in the middle. I know there's a counter argument that says, why should we invest in 70%? But my counter argument is this. How sure are we that we're not going to have another deadlier variant like the Delta variant? It is because of that eventuality that there could be worse variant that would threaten our survival. And we are saying basically 70% is the minimum number of people that should be vaccinated around the world. Not only from a health perspective, but from an equity perspective, is our measure for everyone to have equal protection. Why should the people in the West have more than 70%? Why should we ask less from ourselves? It comes back to the second question. How do we then accelerate to achieve that goal? I was recently in the DRC with UNICEF, WHO, and Gavi. They have formed what they call the COVID vaccine coordinating platform, basically to make funding available to countries, to bring expertise to country, and to bring political leverage to countries. So in Africa, we were part of the team, give them the expertise, sharing experiences from other countries, to help them with political leverage and provide funding for us to accelerate the demands and vaccines. We have evidences to show, I'll share to you, for example, in Ethiopia, Uganda, and Kenya, where there is preparation, adequate planning, and investment in mass communication, behavior change. We see that COVID vaccine has gone up. A good example is Ghana. The president took his vaccine. It's about 1 in 3% in Ghana. So it can work. There are islands of success that have shown us that if you build the momentum to accelerate, we can achieve the 70%. And the 70% is a health security issue, it's a health equity issue. So we must try our best in Africa to achieve the 70%. Now that we have the goodwill, now that we have the funding and the financing, because what is happening is that both the World Bank, Gavi are all coming together and providing financing for countries to help increase vaccine uptake. It's an opportunity that we should not lose. But also we can take upon ourselves to ride on the momentum of COVID-19 to build a better health system for next time. Thank you.
Thank you very much, Dr. Fala. There's one more question here. I'm trying to summarize all the questions. This is from Ida, our Global Health Advisor. Her question is, when people ask why West Africa seems to be less affected by COVID than other regions in the continent, what is a quick, efficient response, Dr. Fala?
The quick, efficient response is that we don't know. Honestly, I went to a country that is about 100 million people, less than 1% vaccinated, and this is the same question they asked me, why are we not dying? We don't know the answer. There are several other theories propounded, maybe pre-infection with other diseases that are giving us cross protection. There are many other answers. That's a good answer. But the question is the uncertainty of the future. No one knew that the virus would spark up in China as it did before, where China went into panic mode and lockdown. We don't want to be caught in a situation where a deadlier variant comes and we are not vaccinated. We don't know the answer, but we don't want to think that we are out of the woods, that we are not in safety zone to relax. We have data to show that countries that relax so much have outbreak. We also know that there are certain trends. We see that the trend is one. Around the Christmas season, we always see increase in cases. Around June, July, we see increase in cases. We've seen the trend for 2 years. So I would say we should not let down our guards, even though we have not had death and we don't know the reason, but that does not rule out the possibility that we can have a worse variant. And the best we can do for that place of doubt is to be prepared. Once you are prepared, then it's better for you.
Thank you so much, Dr. Fala. Just a short question. This is the last question. This is from Vani Calvin Siliv from Liberia, from Local Voices Liberia. This is a question to you, Dr. Fala. How do you rate the effects of misinformation in vaccine hesitancy?
It's very disastrous. It is destroying us. With this on study, we realize the worst group, the most unvaccinated group today in Africa are those from 18 to 40. And it's because one point in time we give them information that they are protected, and so they don't want to get vaccinated. Of course, we have amplifiers of the misinformation, the social media, everyone can go on it. So much damage has been done. But one thing I've learned from our days of working with Ebola to COVID, misinformation and disinformation can mushroom and amplify in the vacuum of the lack of real information, the lack of authentic information by people who are trusted. That's why you are journalists who are trusted. The misinformation will fill those gaps. So you have a major role to actively research and engage the people, because if you create a vacuum, it will get filled by the misinformation. When people are trusted, it's work. And those of you that saw me when I got vaccinated in Freetown, I went on Facebook, I showed my vaccine paper. Other people got vaccine. Many persons wrote me. So you have a very strategic role as media practitioners, as journalists. People respect you and look to you. Use that trust currency to ensure that you do not leave a gap. Because remember, whenever there is a gap, misinformation, disinformation will fill it and will do more harm. Thank you very much.
Wow, that's great, Dr. Fala. Thank you so much. And what an inspiring dialogue. Now, unfortunately, we have to close right now. And first, we would want to thank our Internews Health Director, Megan Miller, for her kind support and encouragement to the team. A big thank you also goes to our Global Health Media Advisor, Ida Jos, for her inspiring leadership in this project. And a special mention goes to my colleagues, Dr. Jaya Shrida, Michael Slasvidal, Adele Baleta, Alpha Sepeni, Christoph Hitayezu, and Tole Nyata for helping this regional media dialogue get off the ground. And to Professor Dr. Moranige for agreeing to be moderator at the last minute. We also thank the discussants, Gideon Kawame, Babatunde, Okunola for their availability at such short notice. To Dr. Fala, as we say in Portuguese, muito obrigado. Despite his hectic schedule and emergency work with Africa CDCs, he managed to say yes to this regional media dialogue. Thank you, Dr. Fala. We also want to thank our RIT Director, Julie Langer, and the RIT team for their support to this project. Last but not least, we thank both Vince Blazer and Nadia Pembert and all at the Sabine Vaccine Institute for their continued support to this Let's Talk Vaccines project. To all the participants, Internews thanks you from the bottom of our hearts. We wish you every success in your work in reporting accurately on COVID-19 vaccines. Remember, and please remember, accurate information saves lives. Thank you. So before we go, I think we have to turn on all our cameras for Christoph to take a shot of all of us here. Yeah. Okay. Christoph, on to you. It's okay, Christoph?
I'm in it.
Right. Can you turn on your cameras one last time? And also thank you to the interpreters, Judith and Jermaine. I forgot you guys. Thank you. Judith and Jermaine, you want to turn on your cameras? All right then, thank you.
Thank you and bye-bye.
Thank you very much. Thank you, Dr. Fala.
Thank you, everybody.
Thank you. Muito
Bye.
obrigado. Have a good night. Thank you.
Yes.